Welcome to Call the Nurse. Today, I am so excited because I am joined by a very special guest, not only a dear friend, but an incredible doctor as well. Dr. Marwa Kilani, born and raised here in Los Angeles. She has worked for a hospitalist for 7 years. Let me record that again. She worked as a hospitalist for 7 years. And then at that point in her career, she found passion in palliative care and underwent board certification in palliative care, hospice and palliative medicine in 2010, and transitioned into the role of medical director of palliative care at Providence Holy Cross Center, where you currently work now, where I've had the privilege of working with you. So welcome,
Thank
Dr.
you. Thank you so much. This is really an honor to be with you, Mindy. I mean, you know how much I love you, and I've always admired your work, and your passion for healthcare has been truly evident. And anytime I know I see you on the unit, I know that unit is functioning at a whole nother level. So I am happy to be with you today.
I appreciate that. I feel like we've collaborated together as
Oh, so
professionals
many
with
times.
families. And then our kids were
Yeah.
in theater together at school. So,
Yes. And at school
yeah.
together.
So I
And
think it's
oh,
really cool.
man.
We've been able to, not everybody gets to see kind of both sides of
Yeah.
our world, especially in the medical field. It's not like a lot of husbands get to see us. Ours do because ours are both.
Yeah.
But at the same time, they don't get to see that side of being in the hospital and as moms. And,
Hmm.
incredible mom as well with,
Thank you.
it's funny because I always say, like, yes, you have your twin boys, but really all that matters are those dogs. We don't even show pictures
100%.
of our kids anymore. We just show pictures
Never.
of our dogs. Yes. So, you know,
So true.
but one of the things that I have always, admired about you, I feel like you have probably one of the most difficult positions at the hospital, but you have such a heart, for people and end of life and palliative care. I think palliative care, I never really knew. I think people get this really confused with hospice. And so that's some
Hmm.
of the things I want to talk about today, kind of what
Hmm.
palliative care is, what you do, having some difficult conversations with family members. So, yeah, if you could just let us know, tell the audience, these are conversations again that people are like, why are we talking about death and dying? Because nobody wants to talk about it. And it's inevitable. It's one of the only inevitable things that are going to happen to us in life, right?
100%.
What exactly does palliative care include, and how is it different from hospice care?
Yeah. And so one of the things that we always say is death and taxes, right? Like those are
Yes,
the inevitable. But
yes,
sometimes you can get away with not having to pay
that
taxes.
is true. For a while, at least. Unless death comes first, and then you've gotten away with it. I also say that I see the most greed come out in death and
Oh,
divorce.
oh,
So, which is
oh.
why it's important to have some of these conversations as well, because we start to see family members get all,
Oof.
crazy at the end of life. So, but I think
Yeah.
people, I've even had patients to where they've heard, well, Dr. Kalani from palliative care has been consulted, and they get like almost
I
like,
know.
well, why? Why is she coming in? Automatically they think it's a death sentence and
Yeah.
why is she here? Why is it and I wonder almost how it came that hospice and palliative care were the same thing. What are the different?
Yeah. So hospice care really formally started several decades ago, really attended to the end of life care for patients with terminal illness. And it was a movement that started uh, in England and by Cicely Saunders, she's considered the pioneer of hospice. The thing that came out of hospice was the fact that we were doing such a good job at caring for patients with serious illness
Right.
that patients were actually living longer. And patients are living longer and longer with some pretty serious illnesses with every year that has gone by. But the patients are still struggling with their quality of life. So, hospice, I look at as more of a definition for the purposes of insurance. I look at it as you need to be certified to be on hospice. You need to be certified by two physicians. You need to have a terminal illness that is no longer undergoing any curative treatment, and you have a prognosis of 6 months or less.
Got it.
Now, some patients may last longer than six
Sure.
months on hospice, but typically, I would say probably the average would be fairly short. We're talking weeks to, maybe a couple
Yes.
months. But palliative care grew out of that really because we were doing such a great job at attending to people's quality of life and whole person care and attending to their physical symptoms and their psychosocial needs, their
Sure.
spiritual needs, their emotional needs that, in this day and age with how busy the clinical teams are, that they
Sure.
can't attend to a lot of these
Right.
details.
Right.
And so our team is really honed in on just that aspect. How do we make this disease process better for you? And how can we make you living better so that you can really withstand all of these really crazy aggressive treatments and have a good quality of life
Right.
and be more comfortable
Yeah.
and have good relationships?
Yes.
And so palliative care has no restrictions. Frankly, I've seen patients who are pregnant, who have babies that are expected to have a serious illness. So,
Oh,
some maybe some type of congenital issue. I've seen elderly. I think my oldest patient was like 108. The age range varies. I'd say on average, we're looking in the 50s. Most of our patients are in the 50s. And I've seen patients starting at stage 1 of a disease process and some at the very terminal phase where they're, maybe got hours to live.
wow.
I see trauma patients, people
Yes.
coming in, 15-year-olds who, are on their e-bikes,
Yes.
who've had pretty traumatic brain injuries
Right.
after having an accident, and help them try to regain some quality of life
Sure.
from this traumatic injury.
Right.
So that's oftentimes when I get to see Alon is
Yes,
is
exactly.
is
My
is
husband,
during
absolutely. During those trauma times, and
the
he's like,
trauma times.
I'll fix their bones, but Marwa, you figure out this part and the pain,
Yeah.
comfort, because I just fix.
Manage their pain, manage their anxiety, manage their families who are like in
Yeah,
total distress.
absolutely.
So palliative, the best thing about palliative care is we're doing like all the cheerleading, all the symptom management, and really just caring for the individual beyond the disease.
Right, right.
And it is just such rewarding work. And, having come from being a hospitalist, like I can really hone in on some of the things that are really need the focus at that point.
Sure.
And so it's been a very rewarding career for me.
Mm.
It's been a lot of fun. I get to work with some really awesome people.
Yes, yes.
We've got a great team, and then I get to work with all of the physicians and staff throughout the hospital. So, I mean, I can't think of a better job.
Yeah, it definitely
It's
is
great.
collaboration with,
Mm.
a lot of people, involved. I've even seen where you can have somebody on hospice and really
Yeah.
like they kind of surpass, and then
Yeah, they
like,
outlive it.
well, this isn't really hospice anymore. This is more of a comfort care or
Yeah.
because as you said, they're living longer because they're
Yes.
comfortable. I do find
Hmm.
the families tend to be the people that you have to, and us nurses kind of have to come in and manage as well,
Mm.
sometimes even more than the patient. And
100%.
right,
Hmm.
I feel like sometimes the patient
Hmm.
is at ease with what's happening. It's the family around, which I know how it is even being a parent, right? But what are
Yeah.
some of the common misconceptions about palliative care that people have?
I think the biggest misconception is that once a palliative care consult has been put forward, that their curative or potential for curative treatment's going to stop.
Agreed. Yes. That's why I think
That,
so afraid of like, well, why is she coming? It doesn't mean you're
oh,
gonna die, right?
no,
Right.
no. I mean, I currently have a 61-year-old patient who, was relatively healthy, just high blood pressure, it was being managed, but she had a pretty devastating brain bleed. She's
Mm.
61. I mean, she's just like, just a little bit older than I am. And as soon as, they consulted palliative care, you could almost see like the husband's expression just like sink. And
Mm-hmm.
I'm like, no, if anything, I'm your biggest cheerleader.
Yes.
I'm going to be the one to like brainstorm around how can we do therapies? How can we make her more alert? How can we attend to any sort of symptoms
Yeah,
that might be afflicting her? And also provide you the support that you need
sure.
because he was in turmoil, just
Absolutely.
absolute agony. Seeing somebody who was so high functioning
Right.
now become bedbound. And I'm like, it's not going to happen. We're going to keep pushing forward.
Right.
I'm your cheerleader.
Yes. Absolutely.
And every time he sees me now, it's like whole nother
Yeah.
perspective.
There's some hope.
Yeah.
Does your care, obviously it's in the hospital and we get those consults. Does it
Mhm.
continue at home as well?
Yeah,
Services?
we have the ability to enlist our community-based teams. You know, our health system has been pretty awesome in regards to palliative and hospice. They have very robust community-based, home-based teams too, where the team can actually go and visit the patients at home.
Got it.
There's also clinics that have been, there's like, one in Burbank and Torrance. So we have a few clinics that palliative care services can be provided there too. But yeah, the home-based team is really essential to carry on those principles,
Yeah.
continue to support the patients, and a lot of times help with their pain management, which can be pretty intense.
Right, absolutely.
So
I think a lot of patients and families are afraid when they leave the hospital, they're not going to get that type of care at home. So
yeah,
it's nice to have, there is a team and there's resources
yes,
outside of, you can do this at, at home as well.
yeah,
How,
yeah, it's
how
great.
families, I have a lot of people who ask me like, gosh, how do you talk about death with families or how do you approach that?
Yeah.
And I do think that there's this, I don't know, a stigma a little bit
A
about
stigma.
don't want to make mom or dad or brother or sister feel uncomfortable that we're trying to plan their funeral before they're gone, right? How do you feel like some families can
Yeah.
approach that topic of advanced directives or DNR, especially in cultures that just we just don't talk about that? I mean, I have a 100
Hmm.
friend, Faith, and
Oh, right.
talk
Yeah.
about death. And she's like, I'm not participating. We don't discuss that. And I'm like, you have two daughters that need to know what you want because
Yeah.
where conflict starts to happen, when that time comes, let's hope it's not for, whenever, but that those conversations, are really hard. So what kinds of conversations do you have with families when it comes to kind of getting your affairs in order? But how do you even approach
Hmm.
this concept of DNR advanced directive before, it's even time?
I think the most important thing around advanced care planning is really the concept that advanced directives are not to be used as an end of life tool.
Hmm.
I always say that an advanced directive should be put into place as soon as your 18-year-old turns 18.
Wow. Interesting.
So for you
Yes.
and for me, because my boys are going to be 18 in a few months,
Yes.
we are going to have a conversation about who's going to be making their medical decisions. Because remember, as moms of new adults, we
Yes.
probably still want access to their medical records
Yes,
and
we do.
right and the
Yep.
ability to
Not
make
only that,
healthcare
but we want to
decisions.
make the decisions, not them, right?
Correct. Correct. So advanced directives really should be started at 18. And I don't know why we haven't incorporated it
Hmm.
with like our voter registration or, in a health class at, at school or something along those lines, because it's important to start the conversation early.
Right. Almost make it normalized to talk about this.
Normalize it.
Right.
Normalize it. And there are some states that do this really well, like Wisconsin does, advanced care. They're probably the leaders in advanced care planning. Their health systems over there are like, they take advanced care planning to a whole nother level.
Interesting.
And they try to, get past all of the cultural, mishigash, or I'm going to throw out a Yiddish word there. All the cultural crap.
Yes.
That can really interfere with that level of planning. But we want to try to normalize it. And an advanced directive is really who can help make medical decisions when you don't have the ability to make the decisions, or who can access your medical records, designate people who could be your surrogate decision maker.
Right.
It could be as simple as that.
Yeah.
So if we start normalizing that early on, I think that would make a huge difference in our society. And it will get past the whole cultural stigma, if you
Right.
will.
Yeah.
Now, when we talk about more of like the hearty, meaty sort of like what would you want for your wishes,
Yes.
a lot of times people say it in context of, seeing TV shows,
Yes.
seeing other people go through ailments. Oh, I would never want to be on a machine like that guy,
Mhm.
or no, I would never want to have CPR like that. That just looks so painful.
Until it happens.
So until it happens. So, as family members, we start to really think about these things and take things out of context.
Right.
and make mental notes. But there are tools, a lot of different advanced care planning tools that can help people get to understand who they are and what is meaningful to them so that they can hone in on some of those elements of end of life, that things that could come up with either serious illness, terminal illness, end of life care,
Right.
that could be like the game stoppers.
Sure.
No, dying in a hospital, that would be a deal breaker.
Mm.
Or being in a nursing home is a deal breaker.
Or having a
So
tube or things like
having a feeding tube.
right.
Exactly. These are things that a lot of times come out of context. And when I start to introduce differing types of levels of treatment that we can provide, it's a huge menu, as you know.
Yes.
I mean, we have a whole menu of things that we can do to, keep patients alive
Right.
artificially with very minimal, improvement in the actual illness itself.
Sure.
And so we have to, kind of take it at face value. This is where we're at with your condition, with your illness. Given this scenario, and given that perhaps maybe you're not going to improve, how would you want to live your life?
Sure.
And then you have conversation.
Yeah. And it goes back to that quality of life you're talking about, right?
Absolutely.
And not only that, I find when you're having those conversations, when it's kind of already started, emotions are
Mm-hmm.
already involved, right?
Oh,
We've already
100%.
thought about, oh my gosh, what happens if this? I find it's better when, I had a patient recently who needed dialysis and literally
Yeah,
given like a not great, outcome if he didn't. And he told his
right.
family, he's like, I don't want to live on dialysis. I don't
Yeah.
do it. And but they're like, but dad, and it got
Oh,
it got kind of emotional. And
yeah.
he just felt like that was kind of a deal breaker. But he was, and I told them, I said, he's alert, he's talking to you, like he's able
Hmm.
to tell you without you. They did end up, changing his mind,
Of
but
course.
they still were able to have that conversation though. Instead of
Yeah.
dad's not alert, what would he
Hmm.
want? And even if they did
Hmm.
know what he wants, it's just so emotional at that point to have those conversations. That's why I think we got to take the stigma out of it because it really relieves you from guilt, from
Mm,
pressure, because we've already had
absolutely.
this conversation. I mean, it's interesting you say 18. I don't know if I ever would have thought about that, but you're
Hmm.
right. It kind of starts, if I talk to my daughter about those things now, it would be
Hmm.
normal for us to continue to have those, conversations. But I think
Hmm.
it does get really emotional when it's there. Maybe mom and dad are, again, I say mom and dad, it could be anybody. Um,
Right.
they're not doing well. Now we're not. I know my nurse brain goes out the window when, like, if it's my kid that's hurting or if it's my own
100%.
parent. I can say all day, my mom has already told me, do not put me on a ventilator. Just
Yeah.
don't do it. That is her.
Hmm.
Do not put a feeding tube. Do not put me in
Nope.
a nursing home. That is
Hmm.
told me that. I'm glad she's told me that because I know when that time comes, I will know every bit of information as a nurse, that
Hmm.
quality of life. She's not going to have a life. She's not alert, but it's still my mom and she still is a warm body there, right?
Of
It's
course.
hard to let go, but if you've had these
Yeah.
things discussed prior, there is
Yeah.
kind of comfort in, okay, this is what I would want, but this is not what she's asked me, to do. I think those are like really, really key because I have also found that's when siblings start
Oh
to,
boy.
right? Yeah. How do you guide those families who just are not on the same page when it comes
Oh,
to
and
life
it's
and treatment?
we're lucky if it's just
Oh,
two
yeah. Oh,
kids.
usually there's more.
Usually it's like six kids, nine
Oh, yeah.
kids.
Yes.
We've had families, right, that are like
Oh, yeah.
15 kids and everybody has an opinion and you're
Yes. And
like,
they're
oh,
all
geez.
calling. We're like, let's designate somebody. Like, you got five siblings calling, and we're like, guys, we can't give updates to all of you. Let's designate somebody.
No.
But you're right. It's not
Yeah.
really just two. There's a
Hmm.
whole gamut. And then you got coming out of the woodwork.
Cousins and oh, uncles and everybody has
Yeah.
an opinion. Everybody's
Yeah.
got an
Yeah.
opinion.
My niece is a nursing student and she says blah, blah, blah.
I
Right.
know.
I get it. I know. We've all been there. But those are difficult conversations to have. I mean, you and I,
Yeah.
we have them, but when people are in it, it is like not letting mom go. We are
Oh yeah.
intubating her if we need to. And then you got brother going, but mom specifically said, no, I don't want.
No.
How do you handle that?
Oh
Because you
my goodness.
that's when we say, Dr. Kalani, could you come to room 13? Please?"
I know, right?
We're going to step out of this one, right? Yeah. How in the world? And how do you train
Oh
your
my
team to
goodness.
deal with this?
Oh boy. Yeah, it is you're in the moment. You're
Yeah.
in the moment with this family.
Yes.
And you really, if you've got a patient who's crashing and we need to make decisions quickly,
Right.
we're in the moment when we need to figure these things out immediately.
Yes.
Mom said she never wanted to be on a machine. We're not putting her on a machine. If she's told somebody that, we need to honor her decisions.
Right.
And we need to impress that upon the rest of the family. Like, why would you want your loved one to suffer?
Yeah.
Why would you want to put your loved one through that? Because you're not ready to accept the finality
Sure.
of your loved one's journey.
Right.
And that I could say that and it sounds really lovely, right? The way
Right.
the way that we can coin it. The reality is like half the time we're still doing things against the loved
You
one's
are.
wishes,
You're so right.
right?
It's every day.
Every day. And so sometimes what we'll do is we'll say, okay, we understand that this isn't something she would have wanted.
Hmm.
Let's do it as a time trial.
Right.
Let's take this, in a very short segment of time. We're
Kind
not
of
going to do
honoring,
things
right.
to
Honoring what they need in the moment, right?
exactly
Yeah, what the
honor what
family
they
needs.
need in the moment. And then let's readdress it in, let's say, 48 hours.
Sure.
Okay. And then we go from there.
Right.
And we keep it in the moment. I try to avoid, when patients are not doing well and they're crashing, I try to just keep our families focused on the concrete, what is in front of them,
Right. Kind
so
of.
that they're not overthinking the whole scenario and thinking about, you know, nursing homes and things like. I'm
Yeah.
like, we are not
Yeah.
anywhere near that.
Right. Right.
you
Trying
know,
to, let's bring it back to where we are right now. Right.
exactly.
Yeah.
And so it's great when you can have these conversations in advance. And then also knowing that we have so much available to us to temporize. We've got so many devices, so many medications that are available to us to help kind of keep our patients as stable as possible without making them have to rely on these life-sustaining treatments like a ventilator. We have that ability. We can
Yes.
use external, BiPAP or high flow or, medications to support their blood pressure. Those are all considered treatments. They're not life-sustaining
Sure.
until you get to the point where they really are declining.
Hmm.
And at that point, you've hoped you've established enough of a relationship with that family
Right.
to then allow them to say, okay,
Yeah.
we're at peace with this.
Well, and I think sometimes when we've gotten to that point, we've given that time limit, they can see that their family member, they
Oh,
are struggling, right? Like they see
yeah.
it, they hear it. I know one of the
Yeah.
things that I hear a lot is, well, and I get it, especially if you're religious,
Uh-huh.
God will take her when he's ready while
Right when it's his time.
they're on a ventilator.
Mm,
And it's hard for me sometimes because I think if that's the case, then why do we have her on life support? Because without this
mhm.
ventilator, she wouldn't be here. So if it's
Right.
truly about that, then
Right.
she probably would have already been gone. So but that's a hard distinction, I think, for people, because if something can sustain their life, or I don't want to take a feeding tube out because
Right.
to starve, right?
Right.
I think when
Right.
these advanced directives and ventilators or not ventilators or feeding tubes, I think they need education too on what that really looks like, and feeding somebody when
Absolutely.
their organs are already shutting down, that's actually more torturous, right?
Absolutely.
Right. So I think they
Absolutely.
need education on what all of those things mean. It's easy to say, I don't want to
Mhm.
be on a ventilator, or I do, or do it until it's not there anymore, or don't put a feeding tube in me, or put a feeding tube in me if it's going to keep me alive.
Right.
Maybe it may keep you alive, but you're going to suffer, right? And that's not it.
Right.
So it seems like
Right.
people really need education and not maybe watch movies or, TV shows on how to guide them. right?
Yeah, yeah, exactly. And I mean, it's what we see every day. We
It
see
is.
that every single day. And the patients that are coming into the hospital are just tremendously more sick than they've ever been,
Right.
carrying a slew of conditions.
Mm.
And their quality of life is horrible. They're suffering tremendously. Families are they don't want to lose hope.
Yeah.
And I think when you try to redefine hope for them,
Right.
that helps them understand things better. So I'll oftentimes try to redefine hope as let's hope for some comfort. Let's hope for peace.
Yes.
Let's hope that they're not going to suffer.
Hmm.
We do the best we can, but again, it's all in the moment and it's all about, the relationships that you set up with patients and families, letting them know that you're sincere, you're honest,
Yeah.
you're not just passing through and just be like, hey, yeah, you're terminal,
Right.
I'm out.
Right. I'm
No,
not
that's
needed here. Yeah.
right.
I think people don't really understand. I mean, we really do put ourselves as much as we
A
can. We
lot.
put ourselves in their shoes. Like again,
Yes.
we have all the knowledge. We know probably what would be the least amount of suffering. But I try to visualize, okay, if that were my mom, what would I
Mhm,
be, what would I be feeling? I
mhm.
try to really put myself in their shoes because they're the only ones that had that relationship with that parent. They really know deep down what their mom would want or not want. But what do you think is one thing, like if you could, think of one thing that you wish every family knew before their loved one reached this stage,
Mm.
what would it be?
Most importantly, who can make your medical decisions for you? 100%. Like that is first and foremost. We need to make sure that we're talking to the right people when the patient themselves are not able to make decisions.
And when you say right people, does that mean who you can trust or who you really know is going to do what you've asked them to do?
Correct.
Probably not the family member that's the most emotional, maybe in the in the family, right?
And that's a lot of times that, you may want to not talk to the most emotional person because they may not be able to see objectively
Right,
what's the best thing to do.
right.
But you just hope and pray that that patient chose wisely,
Yes,
and that they weren't just like, oh, I'm just going to choose kid number 3 out of 5.
right.
They're the middle kid. Let them make the decisions.
Mhm.
You really hope that, they've chosen kid number 4 because they've spent time with them and they've relayed information that has to do about quality of life. I love being in the garden, and if I can never return to the garden,
Mm,
that's just not how I'd want to live,
mm, mhm,
right?
mhm.
Um, or I think that my religious practices are so important to me, and if I can't do my prayers, I really just want to start,
Yes,
thinking about my end of life
right. Yes,
and meeting my God.
right.
So it really is very much who is that person that knows you through and through, who can really interpret the clinical scenario and how that's going to affect that loved one.
Sure. And
That's the
probably
first and
in reality.
foremost.
Yeah, absolutely. I think it's great advice. And I think in reality,
Hmm.
you have a number of family members, when they're really honest, they would really say, yeah, that's probably the person that
Yeah.
we look to, that we,
Right?
they probably all know it's probably that person. I remember when you were just talking about if I can't do this, I want to make other decisions if that person is, still alive and alert and able to talk about it. I had a family, it was my first year of nursing in the ICU, and it was this, I believe it was an Armenian man, and their
Mhm.
culture, food and eating, together was huge.
100%. Oh,
I think he
yeah.
had a cancer diagnosis. I don't remember completely, but he was able going to live longer only if they did a feeding tube, but he was never going to be able to physically put food in his
Hmm.
mouth. But he could live longer, he could be. And he was like, if I can't eat, then I have no life. Like eating
Yeah.
and having dinner and being with my family is, and he was alert. He was very aware. He was like, I can't bear the thought. It's just that's not going to be quality of life. Yes, my family would have me there, but if I can't eat the food and smell it and know that I, want it and only from a feeding
Mhm.
tube, he's like, I don't want it. And that man ended up, going on hospice, and he ended up passing, but his family was very aware, and it was so hard. But I thought, what a gift, really, that he was able to communicate that to them. But
Yeah.
a hard, hard kind of reality for the family, right? That was
Oh,
but that's one of those things to where you talk about beforehand of
huge.
if I can't eat, or like you said, if I can't go to my garden, or if
Yeah,
I can't, if I have to be in a hospital where I don't have my dogs around me, whatever it may be,
exactly.
then there's no
Exactly.
conversation. So, what do you
We
think?
had a 100-year-old actually just last week that I mean she came in, what did she, I think she may have had just like a urinary infection, something mild. It was like not a big deal. And but because she's 100 and she's really, care dependent, bed bound, she has a caregiver, she's got her kids taking care of the whole thing.
Sure.
Um, it was really hard for her to get out of the hospital really quickly. So it took her a few days to get out of the hospital. But that was the most important thing was
Mm,
she needed to get back to her dog
yes.
and her dog needed her too.
Yes.
So,
Yes. You know what?
and
I think I may know who this was. Yeah, I mean, it's funny how we
right?
know each other's patients. It was someone that a dog came the other day. He was like, and
Yes.
this dog, they had, I don't remember this one being 100, but this dog came to the hospital, and this dog had terminal cancer as well. This woman
Oh,
had terminal cancer, and they had been
oh,
inseparable for 13 years. So, you know,
oh,
and somebody in the hospital is like, there's a dog barking in there. And I'm like, that dog's not barking. That dog is wanting to be, with, a family member. And I thought,
yeah.
we really going to pick that battle right now? Like
Yeah, seriously.
she's dying. This dog doesn't know a life without her. I mean, those are the things that I think people don't realize kind of what we deal with too. Like we're not just
Yeah,
we're dealing with everybody else around also. And sometimes I'll even tell nurses, like, is that really the battle you're going to fight with that patient right now? That
right.
the dog shouldn't be in here because I can't do my work. Like she didn't know. She didn't ask the questions of, who is this
Yeah.
and this dog is sick too. And she's had
Yeah.
15 years. And you just think, just ask some questions. Just, sometimes I think
Mm.
doctors, nurses, all of us, we get in our daily tasks, right? And we
Yep.
don't
Yep.
stop to ask questions and what does this person, need right now? And listen, if I don't get to have my dogs around me, I'm gonna have a problem, right?
Oh, oh, me too. Me
Yeah,
too. I mean,
absolutely.
that is 100%,
Yeah.
you
Is there
know.
anything else? I mean, I think we've really touched on a lot. It's been such great information. Again, some of these things are easier said than done, to have these conversations. But is there anything else that you think we can do now while we're healthy to make this
Yeah.
process easier on loved ones later?
It's really about being open and honest.
Right.
Talking about your fears, talking about the things that are important to you. Every day I see patients that are they're scared
Hmm.
of whatever that could be. They're worried, but they don't want to talk about it. They don't want to talk about it with their loved ones. And so we try to get them to open up to us so
Hmm.
then we could try to get them to open up to their family
Yes.
so that they can have some good conversations. But it's just so critical that conversations,
Well,
you
it's
know?
interesting because we've been talking so much about us talking to the family members who
Yeah.
are sick or potentially going to be sick. But you just made a good point that sometimes the patient is actually okay. It's them not wanting to have the conversations with like maybe their kids or
Oh, yeah.
or their husbands because they don't want to upset them or they don't want
Right.
to make them sad because they know they're dying or they don't want to yeah, they want to make it comfortable for them, which is
Yeah,
really
we
interesting.
we we had a patient like that yesterday where the patient she was ready. She was really more end of life appropriate, but her husband was not ready. And it really took him quite a few days to understand. But he had such a hard time accepting it, and he's just, I'm not happy with this. And I'm like, I know you're not happy with it, hon, but this is her journey. This is her life.
Yes.
I know how much this is hurting you and how much you love her, but we have to start thinking about her personhood and
Right.
who she is and how this is affecting her. And he was like, he was resolved. He finally, kind of gave in, if you will,
Sure.
but was there, every minute of the day, every second of her care. And we just smothered him with love. That's all we could
Right.
do,
Yeah, again, you have
you
to love
know?
up on that family just as much as you have to love up on the people who, are sick. And I've seen patients, I know
Absolutely.
my own grandmother, my mama had 5 kids, and when the final,
Oh,
she was dying of cancer, and when the final son came from Michigan to visit her,
oh,
as soon as he left, she passed away. And so there is
yep.
something you can tell, something is still the spirit of holding on for your kids or your family. And when there's kind of settled, at peace, that there's a letting go process, as well. And for your
Absolutely.
own life, what do you think this work? Because again,
Hmm.
I don't think everybody is built for this, just like I would never be able to be a pediatric nurse, oncologist.
Oh gosh,
I
no.
would not be able to
I
do
couldn't do it.
it's
No.
not something that's in me. What is this work, this path you've chosen in your, medical career taught you about what matters truly in this life for you?
I didn't tell you, Mindy, but I have breast cancer.
Okay, that you're gonna make me cry.
And no, I'm good. I'm stage one. I never got a chance to sit with you and tell you.
Oh, I might feel so bad that I didn't even,
Well, I went on medical leave just for a few weeks, and it was over the holidays. It was not this last Christmas, but the Christmas before 2023. And you had just gotten married, and things were happening in your life, in your world.
oh,
Yeah, and so I took only 3 weeks off to have my surgeries, and
mm,
of course I saw, Dr. Shaheen, just like
oh,
you,
we
who's the
love
best,
him.
right?
Yes.
Love him. He's just like a brother. And so it's, up until then, like I felt like that work was
Mm,
preparing me for my own circumstance. It has changed me. Now reminds me that life is so precious,
right.
and I want to make every moment count. I want to do everything I possibly can.
Wow.
And I'm not going to be sitting back, withering away. No, no
Right.
way. I am not doing it.
Right.
And I want to impress upon people that that's an extremely important thing, is to keep on living
Right.
and to do the things that you love, regardless of, like, yes, you have to power through it. Okay. If you need to sustain a little bit of pain to enjoy yourself, do
Right.
it.
Right. Yes.
So I think that my own health has put me in that position, where I can now understand it and I can help patients relate to it.
Right. Because now
I'm
you've had
going through
that
it.
fear. Yeah. I mean, even
Yeah.
this medical scare I just had, you start thinking
Yes.
of like, oh my gosh, like this, if this is happening, what does that
Right.
look like for me? And then you're in
Right.
control every day seeing it. I can only imagine what you're just finding out a diagnosis, like an official one of like, okay, I do this every day with patients now. Now it's me.
Now it's
I
me.
got my
Yeah.
kids. I got my
Yeah.
husband,
Yeah.
dogs.
Yeah.
Oh
I
my.
mean, the moment that I got my diagnosis, of course, it was, Naveed Iqbalier who's given me my diagnosis over
Me
the
too.
phone,
He's been called,
right?
he's literally like our brother with his
I
radio.
know.
What do you see? Because that's who we trust.
Yes.
We know
Yes.
another radiologist may read something, but Naveed, what do you think? Yeah,
Yeah.
absolutely.
Yeah. He actually gave me my biopsy results,
Wow.
and we were at the DMV, getting driver's tests for the boys.
Mm, mm,
And, it's in the midst of life.
right. It
And
never comes on in any kind of good, timing. There is no good timing for
no,
that.
never any good timing. And, I'm just in the moment, told the boys, this is what we're going to be dealing with. We're going to get through this one day at a time, and we're moving forward, and
Wow.
we're not going to slow down.
Yeah.
And I think if I can impress upon that, upon other patients, to keep focused and, keep looking down the line and stop wallowing in their misery,
Yes.
I'll do whatever I can to help them,
Wow. Wow.
whatever I can.
Not only do you come from just experience in the hospital, but now even your own. I mean, what a
Hmm.
powerful, testimony. If anybody can say it, you can. I've seen mentality really change. And I thought even when I had my scare, okay, I have a choice to like sit and be miserable and scared and like you say, kind of crawl in a hole. And I'm sure there's a time for that for everything, but or I'm just okay, I'm gonna go and do what
I'm
you
gonna do
know
it.
I need to go do. And
Yep.
I've seen people live longer because of their perspective. And like you said, just
Hmm.
the tenacity of like, okay, well, that's what I got. God's dealing me, then I'm going to go and live life to the fullest.
Absolutely. And it reminded me last year when I was going through it, I remember I because I had drains on both sides of
Hmm.
my chest, and they operated on my lymph nodes in the my armpits. And I couldn't lift my arms, and my mom was spoon feeding me my oatmeal in the morning.
Oh, wow.
And I'm like, I'm not doing that.
Yeah,
So I picked up a Lego set because, of course, my boys, they love them Legos.
absolutely.
And I picked up a Lego set and I started working on a Lego set. And I put together a Lego set and got my arms stronger and, just strong enough so I could start feeding myself. Because, I mean, I love my mom and I love that she was taking care
Sure.
of me. I'm not going down like
Yeah,
that.
not going out like that. Right.
Mm-mm.
Well, then
Mm-mm.
that's your personality too. I mean, you're an adventurer, you're just a go-getter and you're always positive. I mean, even the fact that I didn't know that, I've seen you at work 100 times, would have never in a million years. And I know what it's like, especially when you get some kind of diagnosis, especially in the hospital. It can
Yeah.
spread like wildfire. And unfortunately, I've seen a couple of our colleagues recently, getting diagnosed and
Yeah.
I just saw somebody else and I had no idea. We keep it private because it does kind of get out there. We all handle it differently, right?
Oh, yeah. Yeah. Yeah.
Oh, but you're always so happy. You're
I
always
try.
you really are. And you just have this empathetic heart for patients. And I mean, I can't even imagine what you were going through and then walking into other patients' room with the same diagnosis, different
Mm-hmm.
stages, and
Mm-hmm.
having to kind of in some ways put yourself to the side and really be there. Like that's hero status to me, my friend. That's a
Thank
whole
you.
other level. Wow. Well, I wasn't expecting that, but that just is a testament of who you are. It really is.
Yeah, I really wanted to sit down and talk with you about it, just because it was something that was very meaningful,
Mhm.
but we just haven't had a chance to sit
Yeah.
together,
Life.
because usually even during the day at work, like we can steal away like 15
Yeah.
minutes and like
Even
just
that's
sit
been
and
hard.
chat and catch up.
Yeah.
It's been impossible.
Yeah. It's just really been really
Um,
busy. But
yeah,
I
so
appreciate
busy.
you and I appreciate you doing this and being vulnerable and just again, it just you were made, for this role that everybody loves to see you in the hospital. And we have such a relief. Like when we see you on the unit or even Leah, sometimes we're like,
Yeah.
okay, they know how to have these conversations because we as nurses we're like we've done all we can. Like you guys really are, people don't know what a palliative care team, it like they need to do more research on this as well because this is just a really important team that is out there that I think a lot of people really just don't know enough about. So
Hmm.
thank you, and I hope that you're not going to be needing any of that in the near future. You look like
Nope.
you are doing
I
well.
feel good. I
Everything's
feel
good.
good.
It's good. You got those dogs next to you and those kids. So thank you, Dr. Kalani, Marwa, my friend, my
My dear
colleague.
friend.
Love
Thank you,
you.
Mindy.
We will talk soon outside of this
Yes.
and catch up. And I'm just so grateful for you. Thank you for just being open and helping everyone out there with conversations that are really difficult. So you
Thanks
take
so
care.
much.
Enjoy Sturgill and Schroeder and their family, and we will talk soon.
Okay, honey.
Thank
Love
you.
you.
Love you. Bye bye.
Bye-bye.
Thanks for listening to Call the Nurse. I'm Mindy, nurse, mom, wife, navigating life one shift, one story, one breath at a time. If today's episode resonated with you, don't forget to subscribe, leave a review, or share it with someone who just might need a little life support. Until next time, breathe deeply and heal gently, and I'll see you next shift.